Hello everyone, thank you so much for having me. It is indeed my pleasure to share with you some of my work in imaging and machine vision for biomedical robots. My name is Yang Liangqing. Right, so before we go into this technical aspect of the presentation, just a very quick self-introduction about myself. Okay, so I come from GJU UIUC Institute. So this is actually a collaboration between University of Illinois at Urbana-Champaign and Zhejiang University. And so our campus is actually situated in Haining, that is somewhere in between Shanghai and Hangzhou, right? So as you can see, this is actually a very pretty, a very beautiful campus. You have a different scene in different season. All right. So my research area really involve robotics, vision, and imaging. So I look at biomedical robotics, machine vision, and image analysis. So for the image analysis, part of the imaging modality that we usually work on is associated modality like endoscope, ultrasound, and sometimes microscope as well. So as you can see that there are a few exciting intersections between these three different areas of collaborative robots, machine visions, and medical imaging. So there are applications in vision-based robot manipulation. There are also applications in intraoperative imaging and visual navigation. And a lot of my recent work also revolve around image augmented medical collaborative robot, or cobot in short. So this is a very quick glance at the entire, or rather some of the research that I've been working on or am working on right now. Okay, we see that there are vision-based micro manipulator working under the microscope. There are intraoperative imaging and visual navigation by combining two different imaging modalities. We will actually look at this in detail later on. And there are, of course, this image guided or rather image augmented medical cobot, where we also put in immersive technology to help human user to integrate a lot better with with a more intuitive approach. At the same time, there will also be physical contact between human and robot. So how do humans work alongside robots in accomplish certain tasks, especially in the case of a medical application where the patient himself or herself is a human, right? So you are looking at not just collaborative robot, but human-robot interaction. Okay, so here's a very quick look at the development of surgical technology and the role of robotics and imaging. We'll see that this robotics and imaging, they actually plays a very important and influential role in the development of surgery. And in fact, in modern surgery, we see a lot of advancement that is being propelled by these two fields. So if we look at the past of surgery, we see that back in the Middle Age or the medieval periods, before the popularizing of general anesthesia, okay, surgical procedure might not be something that is viable or is not really a mainstream medical option, treatment option, because it is actually very hard to imagine someone having to undergo that kind of excruciating pain uh, while being cut open so as to be treated for their illness. So a lot of time patients will rather die than to go through that kind of pain. And after the popularizing of general anesthesia, this problem is solved, and is kind of a very important milestone where people start to look at surgical intervention as something really viable. But but even somewhere after that, a little bit after that, they realize that not most of the time, even though patient could be treated for their illness after the surgery, they might not survive because of surgical complication, things like surgical infection, and that is why it is also important later on that the medical team realize that it is also important to ensure a clean environment when performing surgery. Okay, so it is after that that surgical procedure or treatment become something viable. And so today we are in an era where we are not just concerned about removing the pain or reducing the risk of the patient of getting surgical infection or complication after the surgical procedure. We are also very much concerned or interested in making sure that the post-surgery quality of life of the patient is being maintained. So that is why there's a need to reduce the trauma inflicted on the surgeon during the surgical procedure, and that involve reducing the level of invasiveness. So this is where imaging and robotics come into the picture. So you see that with sophisticated imaging capability, we can see places without cutting open or extensively cutting open the patient. We can reach places without doing so as well. So we see that in the development of robotics, start off with very humble structure that are just accurate motion. But later on, it gets more and more sophisticated. We are seeing specialized surgical robot, and in this case, the state-of-the-art Da Vinci surgical system, okay, intuitive surgery. We see that in this case, the robot can actually help to execute precise motion given the command by the surgeon. Of course, it is still an assistive robotic device that doesn't really do surgery autonomously or in the clinical setting. Because in research, we see a lot more futuristic advancement. So we are starting to project our vision into the future to see what is really the next revolution for surgical technology. Is it going to be a combination of digital reality that digitize the entire surgical procedure and making sure that it can be executed precisely with no errors? All right. So this is something very exciting, and we're probably going to look forward to that. All right, so let's take a look at the some background information of minimally invasive procedure. So I'm just very quick walkthrough of this background information. When we talk about interventional procedure, okay, in this descending order of invasiveness, we have open surgery, we have keyhole procedure, and we can have percutaneous intervention. So what you see in this part here, this is actually open surgery, a schematic of open surgery where you open up the patient, you do an incision and expose the organ that is supposed to be operated on. And so in this case, there will be a surgical retractor to hold this open so that the surgeon can actually work on it. So as you can imagine, this is kind of traumatic for the patient. The patient is usually subject to a very high level of trauma. And so this will usually require a longer recovery time. And there with this keyhole procedure, right, this actually allow surgeon to just do smaller incision. Okay, in fact, small parts that are maintained by this surgical trocar. Or, or uh, and surgeon can actually operate on the site without having to extensively cut open the abdominal. And the least invasive procedure, of course, there will be percutaneous intervention where there is actually not even incision required, but a needle-like probe used to puncture into the soft tissue and reaching the right position to either do the treatment or sometimes to do biopsy. Okay, so this can be, say, radio frequency ablation to ablate a certain target. So we see that, of course, by reducing the level of invasiveness, it's going to reduce the recovery time and give the patient better post-surgical quality of life. But at the same time, it's kind of giving the surgeon a harder time because the ease of operation, as you can see, will actually reduce, right? Because of a few reasons that we are going to talk about, right? So if we lease out a problem, the surgeon will have to be constrained by visual limitation, okay, as well as dexterity, okay, because they no longer can have direct visual access to the organ where you are not opening up the scene. And at the same time, they will have to maneuver the surgical instrument constrained to that small entry point, okay, those are surgical ports, usually not greater than 5 millimeter in diameter. All right, so this is kind of difficult, and combining these two difficulties, of course, you have perceptual complexity where you have to coordinate your hand and eye, and this can require non-intuitive mental registration between what you see on the endoscopic display on the monitor that is displaying the endoscopic view and your actual maneuvering of your hand, right? So what you are seeing is not, your hand is actually moving not within your field of view, right? So this can be very indirect and non-intuitive. So what we are seeing here is that we actually have a host of technology from diagnostic imaging. We can use imaging technology to come up or to gain visual access to places that we don't usually can see. But without actual precise execution, all this imaging technology will not translate to actual benefit intraoperatively. And on the other hand, if you have very precise robot capability to execute motions without knowing where to go and what to do based on this image guidance, okay, this is also going to be very limited, right? The effect also zero. So we will kind of bridge this gap because computer vision in its simplest form is really helping your machine to see or make sense of the image that they have. So this can actually be in a form of registration between what is in the image and what is actually in the intraoperative scene. Okay, so one example that I'm going to show you here is ultrasound image guided navigation. We actually use this for a particular treatment for fetoscopic procedure or fetoscopic surgery, where they actually need to treat this twin-to-twin transfusion syndrome problem, where you have twins sharing the same placenta and their abdominal or abnormal blood vessels that transfuse blood from one twin to another. So if you don't treat this in time before birth, this can actually cause death or even lifelong issue with the mental capability of the twin. All right. So one option is to find these abdominal blood vessels so as to treat the patient. But the problem here is that you can't put in too big instrument, too big of an instrument. So the endoscope is usually a very small and thin endoscope. So your field of view is actually very limited. What you can see on the surface of the placenta through this endoscope is really limited. And so what the surgeons are doing, they will use ultrasound to give navigational guide. And so this kind of require very non-intuitive mental registration between the two imaging modality. So we believe that it is important to equip the surgeon with some form of integrated visualization. So we actually combine these two image modality into a single visualization platform. So in other words, we are doing the registration for the surgeon instead of them having to do this mentally, so as to offload some of the mental burden while they are doing the treatment. So what happened here is that we can do 3D reconstruction from ultrasound to obtain the 3D geometrical information of this placenta. And ultrasound can also be used to do initialization by tracking where the initial position of the camera is. But of course, this continuous tracking might be a little bit difficult because of the volume reconstruction time that is required. So we actually use vision of the endoscope itself to work out the motion of this endoscope. So this is a freehand endoscope that the surgeon is moving. We can actually recover the position or the motion of our endoscope, and we can actually piece all this view dynamically onto the 3D scene, right? So the other example is vision-based robot manipulation, where we actually register preoperative diagnostic imaging images and this preoperative surgical plan onto actual intraoperative surgical scene, so that the robot can actually execute what is on the surgical plan, right? So this involves intraoperative scene registration with the preoperative surgical plan or model, right? So when the robot actually understood what is in this scene here, they can actually execute the motion precisely. So we actually do this for one of this radio frequency ablation application for treating liver tumor. So the case here is that you have to do a percutaneous puncture to send this needle probe into the right area so as to do the burning. So there are a lot of planning algorithm that kind of optimize on the burning zone, but this doesn't translate to actual clinical benefit if it is not executed precisely during the operation itself, right? So we have the robot to execute this based on the surgical plan established by the surgeon, right? And we can also use vision-based robot manipulation for doing cell manipulation, right? So these are micro manipulator working under the microscope. Okay, so the idea here is that we can come out with all the vision-based algorithm to do tracking, but of course there are difficulties and challenges because you are working with monocular camera, where you don't really have the depth information and you can't move the camera because this microscope objective lens is fixed. All right, so you have to use some innovation in things like defocusing to kind of compensate for the depth misalignment, right? So we actually work out some of this algorithm and use it for this application. So I will actually let the video do the talking. That is a lot easier for you to understand. We actually have, in this case, a manipulator arm, micro manipulator arm that can be deployed and work alongside uh, a lab microscope. So in this case, it can actually do auto detection, getting the tip of your tool, and it can also do self-calibration. So in order for the robot to be able to maneuver or manipulate these tools in the microscope scene, it will have to do some form of calibration to register its coordinate with that of the microscope scene. So we can actually do automatic calibration, right? So in this case, after doing that, the user will be able to control it very easily, right? So not only that, it can also uh, detect any uncertainty due to the cumulative error over time and trigger the self-calibration and do a reinitialization, right? So this is a lot more powerful than just having a normal detection method. And when we do that, we kind of do it with a lot of to test the robustness, we actually intentionally put in complex environments. Okay, later on you will see that even under occlusion, right, it is able to track this needle tip because whenever it lost vision or visual uh, tracking capability, it will actually deploy or take in the robot kinematics information to make the tracking continuous, right? So even when it goes out of the field of view, right, it can still know the position as you have seen indicated by the arrow. All right. So of course we um, did a few development and present this work in IEEE IROS and eventually published in this transaction on automation, science, and engineering. So this, of course, involved a few things in terms of making it adaptive and robust to this illumination condition, being able to do self-focusing and adjust itself when the error is getting too big, right? So this is the user interface that, as you can see, is kind of intuitive. The user just need to move the mouse. Although in this case, it doesn't have to align properly um, so that you can deploy it easily or readily. But the problem with existing or conventional setup will be that you need to maintain that focus. So you don't have 3D information of the needle, but you're only working with a 2D scene here. So how does the robot actually correct this behind the scene? So if you see this uh, demonstration here, you will see that although you are just doing a 2D positioning, but all these three axes will actually coordinate together to make sure that the needle is maintaining on a focal plane, right? Even though they are not aligned, the robot and the microscope uh, don't have to be in alignment. All right, so these are some of the advantage. And of course, on the vision, uh, computer vision part, we need to make sure that it is robust against the scene. We come up with different algorithm on how we fuse different trackers. Okay, when they run into problem, different tracker will be susceptible to different kind of error. And when that error occur, it should be able to self-detect such an error and bring in a remedy or do failure detection and then failure recovery. So in this case, this is one of the typical fusion between a motion-based tracker and a template-based tracker. Okay, so whenever motion-based tracking or rather template-based tracking is usually very easily influenced by this occlusion of other cluttering scene and stuff like that. But your motion cue will actually take over whenever that happen, that kind of failure happen, and make sure that it continuously track the thing. All right. So of course, the problem with motion cue is that it is also not perfect, right? So at different time, due to noise and all that, it can also give way in terms of tracking. So they have to work hand in hand to work together. And we actually did this on an array of cell for the plant cell. Okay, so not only on single cell specimen, right? So these are some of the experiments that we are able to demonstrate in working out our system. All right, and so we have also the third part on image augmented medical collaborative robot, or cobot in short. Okay, so we have ultrasound imaging robot that help this human to do ultrasound guided percutaneous intervention. And we also work out algorithm that unify the optimal positioning of the ultrasound probe, as well as the contact force between the soft tissue and the probe itself, so as to maximize or optimize the image quality of the ultrasound here. And not just having the robot being able to make imaging a lot easier, we also want the human to be able to work with the robot more intuitively. Okay, so we make use of immersive technology in this case to help realize this. So as you can see, mixed reality can actually even help human control the robot remotely, okay, without too much burden. All right, and you can actually impose the field of view, or rather the endoscopic view within the field of view of the operator. All right. So with that, I come to the end of my presentation. I would like to acknowledge a lot of people, mainly people from my lab group, okay, Intelligent Robotics Research Lab, okay, and collaborators from Center of AR Simon, okay, and some of the industrial and clinical partners. So of course, we do have opening for my lab, especially joint postdoctoral fellowship. You're welcome to join us if you have the capability, right? I'll see you. All right. Thank you so much for your attention.